I'm taking the podium again and taking over the meeting. No, not really. Dr. Heaney had to go back to Los Angeles, so we wish him all a safe journey, but he had to catch his flight, and therefore, because we're behind, he couldn't chair this session, so he asked me to take over for him. We're going to now move on to the session on local regional therapies. This is going to apply to a lot of you. Those of you who have liver disease and things that cannot be dealt with surgically, then we rely on the liver-directed therapies. So our first speaker is going to be Dr. David Liu. Dr. Liu went to medical school at the University of Toronto. He did his interventional radiology in the United States, in Chicago and Washington, D.C. as radiology and interventional fellowships. And then I'm happy to say he came to Portland, Oregon, and he was the first to actually bring yttrium-90 embolizations of the liver to the Pacific Northwest, and he was a great ally there. We were able to get patients to him for that treatment much sooner in our region of the country than elsewhere. And then he did a really rotten thing. He left Portland and came back to Canada. So we've felt the void since, and it's taken us quite some time to recover from his absence, but we're working on that very nicely. But he's not going to be talking about the yttrium-90. That will be Dr. Salem. Instead, he's going to talk about the other ablative therapies like radiofrequency ablation. So, David, we're looking forward to your talk.
Thank you, Dr. Pommier. I guess we have a fairly compact agenda, so compact, in fact, that even before I walked up on the stage, the 1-minute warning sign is already put up. So I think that's just a gentle warning to keep things brief and also efficient. Once again, we're in terms of local regional therapies, we have a number of different options available. We have ablative therapies, and we also have embolic therapies. Dr. Salem will be covering the embolic therapies, and I'll be covering the ablative therapies. There are commonalities between the two, so there may be some redundancy, but what I would also like to do is back up a little bit and talk about the principles of local regional therapy and how they can apply directly towards patient management. I suspect 5 years from now, if I'm so fortunate enough to be up on the podium again, updating people on ablative therapies, that the paradigm will shift, in a large part due to the luminaries in the room that have shared with you their research and also their findings. However, what I've tried to do, or what I will be trying to do in the next 15 minutes or so, is talk about ablative therapies in the context of patient management and care. So a very brief overview over the evidence and the technologies that are currently available. So what we'll do is we'll first outline some of the indications for local regional therapy. I think that'll be the common theme amongst most of the slides that you'll see. We'll overview the ablative technologies available, look at the evidence base for morphologic-based outcomes, i.e. Specific tumors and shapes and how they do when they're subjected to local regional therapy, and then take a look at clinical outcomes. Let's see if we can find some measures or surrogates that may help us guess or predict which tumors will do better than others. If we do have the time, we'll briefly talk about procedural optimization, because as you can imagine, during these procedures, which can sometimes be prolonged, we always want to maintain some degree of safety throughout the procedure in order to minimize scenarios such as carcinoid crisis. We also would like to take a look at the consensus, in other words, what's out there as the commonly accepted therapies. So ultimately, this is a very ambitious hit list, and ultimately, I just want to still keep it in common themes, because as a professor had said to me very early on in my academic career, it is better to uncover a little than to cover up too much. So as a brief summary, conventional wisdom, i.e. if we go back, in the Wayback Machine as to how neuroendocrine disease was thought of in terms of treatment, it was always thought of as a disease of indolent growth, in other words, very slow growth, and only treat when quality of life becomes a measure or a problem, in other words, large bulky tumors, obstruction of bowel, or potentially a compromise of liver function. Resection or surgery was indicated only when massive bulky tumors and progression was demonstrated, and local regional therapy was a palliation for symptoms. Although that is a very clear indication, it is only one of many that now is currently under investigation and also accepted as common practice. And of course, the thought process at the time was that there is no effective overall survival. Since then, as you've seen from many presentations over the last 2 days, local regional control is an option and should be performed if possible, and aggressive tumor debulking in those contexts, both surgical as well as ablative and embolic therapeutic, are really part of what would be considered a contemporary standard of care. Cytoreductive therapy does improve overall survival. That's been demonstrated in a number of elegantly designed surgical studies. And cumulative small therapies may be better than a large palliative therapy. And if I can just reduce down both points into two quick slides, the conventional wisdom is the little boy trying to push the sumo wrestler out of the way when the tumor bulk has become so large that it's difficult to manage. Meanwhile, contemporary therapy is more what I refer to as a whack-a-mole mentality, whereas individual tumors arise, we try and treat them in a more aggressive fashion in order to minimize having to deal with the sumo wrestler. So let's take a look at the ablative therapies in a very brief and cursory overview. Chemical ablation is essentially a historical context using either ethanol, in other words pure alcohol, or acetic acid, which is essentially vinegar, to rupture cell membranes and cause destruction. Usually requires multi-session therapy, and because it's a liquid form of ablation, in other words it's not a transfer of a thermal energy, it can sometimes be unpredictable in its distribution. So for all intents and purposes, this is more for historical reference. Thermal ablation, which is the most commonly used ablation, utilizes either heat or cold, i.e. radiofrequency ablation and microwave ablation creating a heat field, or cryoablation creating an ice ball. With heat-generated ablative therapies, our target temperature is 42 degrees Celsius, in which cell death occurs, and our target temperature not to exceed is 100 degrees Celsius, where steam formation, what's referred to as carbonization, occurs. If you think about carbonization, we see it actually in the campfire and fireplaces when we put a piece of wood into the fire and out comes a piece of charcoal. The problem with that in terms of the current ablative therapies that we'll get into in a moment is that by creating that charcoal and by creating an area of desiccation or dryness, we don't have an environment where molecules and ions in particular can rub up against each other, which is the frictional force which generates the thermal ablative zone. The two current technologies that are most commonly accepted and used are radiofrequency ablation, or RFA, and microwave, otherwise known as MWA. For all intents and purposes, we'll see in terms of outcome measures, radiofrequency ablation is still the standard of care, and microwave, although is an encouraging technology platform and is being used, still has not really substantiated itself to the degree and level of evidence as radiofrequency ablation. However, in principle, the temperatures reached are the same, the ablative zones are slightly different, but same but different. In other words, we're creating heat within a certain range, thereby destroying the cells at the target temperature. Cryoablation is slightly different, and what cryoablation consists of are multiple small needles. And I'm sorry, is there a laser pointer up here? Okay. That's okay. I'll just extend my arm out. You can see.
Odo to the rescue.
Thank you. Thank you very much. Percutaneous cryoablation has the benefit of allowing for multiple cryoprobes, which are usually about less than 2 millimeters in diameter, to be placed within a tumor. When the cryoablation zone is then propagated, small ice balls form and can potentially coalesce into larger areas of ablation. The needles are smaller. The procedure is generally pain-free. However, there hasn't really been a lot of long-term published data, except for in applications for renal cancer and prostate cancer. Once again, the concept of it being that the science is very sound in terms of target temperature being reached and cells being destroyed, but not necessarily with applicable outcome measures, specifically within the liver or especially within neuroendocrine disease metastases. Irreversible electroporation, otherwise known as IRE, the commercial name of the product now available is called Nano Knife, is a fundamentally different technology which uses electrical pulses, which then cause the static membrane, cell membrane, to rupture and involute on itself, thereby destroying cells almost instantaneously. The pulses are usually in about the 500 millisecond range and pulse train of about 10 seconds. So you can create areas of ablation not by heat, but by rupturing the cells through electrical current. It is primarily used as more of an experimental technology, but it does have a lot of promise in terms of not only local regional therapy, but also immunomodulatory therapy. So, with all these toys, with this armamentarium, with this quiver of arrows in front of us, what's the evidence base for what we do? Well, as I was alluding to before, with percutaneous technologies, there's the principle of the science as well as the clinical context in which it occurs. Now, the principle of both the thermal ablative therapies, RF ablation and cryoablation, is the following. With radiofrequency ablation, the vast majority of the literature, actually, in terms of morphologic response, in other words, if a tumor is a certain shape, parallels very closely to a primary liver cancer called hepatocellular carcinoma. There are nuances between the two, but functionally we're talking about a mechanism to destroy a tumor. It's basically a hammer, and we just want to see how this hammer works in this particular nail. With cryoablation, there's very little published data, and it's primarily from the older generation of large diameter probes, which used nitrogen pump systems and glass needles, and also had a relatively high complication rate. For contemporary percutaneous and laparoscopic cryoablative technologies, we really don't have a strong evidence base. However, the proof of principle is there. Ablative technologies in the real world really incorporate more than just the nuts and bolts of the technology, how big of an ice ball, how much heat we can deposit, how big are the tines, where can we put it. It also involves a greater influence in terms of the overall biology. So ultimately, when we're looking at local regional therapy and ablative therapies, we have to talk about not only the tumor morphology as to whether there's an indication for local regional therapy, such as ablation or embolization, but in a greater context, the biology. And in the case of neuroendocrine disease, that means understanding the cell line, the behaviors that make a cell or a cell line more aggressive, and also the presence of extrahepatic disease. In other words, is there disease outside of the liver? So in terms of the morphology itself, let's just focus down on the shape of the tumor and how it responds. The bottom line is that tumors of less than 3 centimeters respond better. Tumors of 3 to 5 centimeters have a higher local recurrence rate. In other words, we can't apply enough energy, whether it's heat or ice, to be able to provide a robust degree of ablation or response, in other words, destroying the entire tumor. Anything greater than 5 centimeter, and this is just a Kaplan-Meier statistic showing the relative degree of recurrence, not necessarily survival, but recurrence within an ablated zone. And this is another very similar study demonstrating the ability to completely ablate within about 90% of patients with less than 3 centimeter lesions and less than 25% of patients with greater than 5 centimeter lesions. Despite the fact that nowadays we can actually purchase radiofrequency ablation probes that look like umbrellas, literally as wide as umbrellas, really the principle of lesions of less than 3 centimeters in size being eligible for percutaneous ablation is something you can hang your hat on. Now, the reason for that is several-fold. Essentially, what we're doing with every radiofrequency ablation when we're putting a radiofrequency ablation probe in place, or cryoablation in this case, is that we're creating a zone of heat that then destroys the tumor. The larger the tumor is, the more heat we have to distribute within the area. If a tumor is larger than the diameter of the ablation probe itself, also taking into account clear margins, which we'll talk about in a moment, you can see that we'll have to increase the number of ablations serially to the point where it's literally a Rubik's Cube of 36 ablations to be able to get a robust removal of the tumor. So 3 centimeters is still something you can hang your hat on. That's not to say that 5 centimeter, 6 centimeter lesions cannot undergo ablation. It's just that it's technically more demanding and also may take a longer time to be able to do a successful ablation. So one important thing about local regional therapy is that the image is everything. And no sooner or better said than whenever you see a picture of Paris Hilton in the paparazzi. But let's put it in the context of neuroendocrine disease and liver management. Ultimately, what we're talking about is optimizing sensitivity of detection. In other words, being able to have the proper image to be able to not only surgically plan, but also look at the morphology of the tumors to see if there's an indication for embolotherapy or percutaneous ablative therapy. So in this case, it's more important to have multiphasic high-resolution imaging as opposed to physiologic molecular imaging, although both are important in the context of clinical care. So what we have here is an arterial scan demonstrating just a tiny little ditzel, which is a metastatic lesion. Now, based on this image, we can't determine whether it's a candidate for embolic therapy or percutaneous ablative therapy. Now, if we just do what would be referred to as a conventional CT scan, which is one that is not multiphasic, monophasic, usually in what's referred to as the portal venous phase, we really can't see where that lesion is. But if we actually use the arterial phase, you can actually see the lesion right there. So this is another stress as to why in these circumstances you really do need multiphasic imaging in order for preoperative, ablative, and embolic planning. So as far as the context of neuroendocrine disease, really surgical resection and ablative therapies operate hand in hand. And the determinants of recurrence are very interesting in terms of the tumor biology. This is a very elegant study looking at a number of patients with neuroendocrine disease, looking at a combination of radiofrequency ablation and surgery and overall outcome based on recurrence rates. And essentially, the common theme is that patients who are midgut or foregut, and also those that demonstrate high Ki-67 in their initial histopathology, have a higher incidence of recurrent disease. So here's the yes category of recurrent disease. Here's the no category of recurrent disease based on Ki-67. So basically grade 3 Ki-67 or higher, which in this case, in this published data, 16% or higher, really incurs upon it a greater risk of local recurrence. Now, if we actually take a look at the other parameters, which are pre-op chromogranin A and 5 HIAAs, they are also correlated with recurrence. But it's very difficult to tell whether that's as a result of that being an overbearing or high tumor burden, or whether that's as a result of the tumor biology secreting more chromogranin. The limitations of the study are that the different RF systems were used. The technologies in radiofrequency ablation are very different. There are probably about 10, 15 probes out there that do slightly different things or variations on a theme. And there's no definition of local recurrence. So how do we stratify local recurrence? And local recurrence means when we do a radiofrequency ablation, or when we, for the purposes of this discussion, what are the chances or what are the things that make the tumor unresponsive or have residual disease within the area that we treated? Well, Berber and Siperstein from Cleveland Clinic had analyzed 1,032 lesions, all comers, 317 of those neuroendocrine, demonstrating essentially that neuroendocrine disease has a much better quote R0 or curative rate within the area of ablation as opposed to all other comers. So that means neuroendocrine disease is actually a very good target for local regional control for radiofrequency ablation. Those lesions that are closer to major blood vessels, and this has been shown in a number of other studies, but it's kind of nice to have it all in one study. Those that are closer to blood vessels will essentially have a higher recurrence rate. And those with what are called ablative margins or clear margins of greater than 2 centimeters, in other words, having normal liver that's been ablated outside of the tumor parameters, will also have a lower recurrence rate. In terms of morphology, we also know from our hepatocellular carcinoma experience that those percutaneous ablations that are done with subcapsular lesions with non-tumorous rims, such as this one here, right under the diaphragm, right under the skin of the liver, in a post-ablation CT, you can see how there's a white area here and a dark area which represents the ablative zone. That's actually a very tricky area to treat. Lesions that are subcapsular or lesions that are very central, in other words, very close to the portal triad. As I alluded to before, large probes are not necessarily better, and greater than 3 centimeters significantly increases local failure rates. In terms of radiofrequency ablation and determinants of survival, another kind of aggregated chart, which essentially shows in these two slides that if lesions are greater than 3 centimeters at time of detection, and this is a Kaplan-Meier survival curve, if lesions at time of detection and treatment are greater than 3 centimeters, it actually portends a poor prognosis to overall response. As well, the tumor volume, which is a reflection of how many tumors there are and their overall volume, also reflects a survival. Other determinants, at least within this study, once again from Cleveland Clinic, involved gender. In other words, women did better than men. Larger liver tumor sizes we've seen in these charts of greater than 3 centimeters, and total tumor volume, which is essentially a function of the largest tumor size or the multiplicity of tumors. Procedural optimization, we'll just go over this very, very briefly. We always want to be watching for carcinoid crisis. It can happen in both symptomatic and asymptomatic patients. So we have to ensure that you receive the appropriate medications and optimization before receiving care. Pre-procedural optimization, so we have to get everybody lined up at the starting line before beginning. What we need to do is we need to optimize a diet. We need to ensure that pre-procedural oral sedation and also conscious sedation during the procedure is performed. If you're nervous during the procedure, it increases your chance of actually developing a carcinoid crisis. Aggressive hydration, dehydrated people have a tendency to go into crisis more. And pre-doses of sandostatin, which is variable depending on the institution, but generally if you're receiving LAR at least 2 weeks prior, and also possibly a sub-Q shot or IV infusion pre-induction or sedation. The other intraprocedural indications are frequent vitals, aggressive hydration, so we want to make sure that we have an IV and that you're very well hydrated in order to minimize the stress on the system, and of course management of acute hypertension, which is the most important thing. If your systemic blood pressure goes above 220 millimeters of mercury, there's a chance that you could develop a hemorrhagic stroke, in other words, a bleed to the brain. So what we have to do is make sure that we have all the tools available should a hypertensive crisis develop intraprocedurally to keep that pressure down first. So generally what's approached is as a bolus of fast-acting what are called beta blockers, and I defer actually to cardiology for this. But we usually start off with esmolol on a fast trip to be able to titrate, and at the same time start with an octreotide drip in order to acquiesce or be able to settle the tumor down a little bit. So what's the consensus? Well, the NCCN guidelines, which are probably the most recognized in the U.S. outside of NANETS, ENETS, UKNETS, and general neuroendocrine guidelines, essentially says that ablative therapy is indicated for those patients who are either asymptomatic or symptomatic with resectable disease, in other words, do surgery and radiofrequency ablation at the same time, or an unresectable disease. It's considered an option, especially if there is clinical evidence of significant progression. Falls under the same line as embolotherapy, and that's why Dr. Salem and I will be talking about very similar themes. So if I was to put it into a nutshell in the next 2 minutes that I have left, essentially what we're talking about in terms of morphologic considerations within the treatment of neuroendocrine disease for ablation is we're looking at ablation first. We're looking at, resection first if at all possible for an R0 margin, in other words, full resection of metastatic disease. We then look at the option of potentially doing complementary therapies like resection and ablation. And if that's not possible, potentially ablation if there are deep lesions during the surgical resection and also lesions of less than 3 centimeters. And of course, if the lesions if there's an oligometastatic condition, which means basically less than 5 tumors within the liver. Embolization for polymets and miliary disease, and systemic therapy as either an adjuvant to any of this or potentially salvage or in the presence of extrahepatic disease. So if I was looking at trying to ablate the ideal lesion or the one that responds the most based on the current published literature, I'd boil it down to patients with neuroendocrine disease with parenchymal lesions, in other words, no capsule, no vessels around them, lesions of less than 3 centimeters in size, less than 5 overall, and ideally with the primary tumor identified and resected. The biologic considerations are much more challenging because really the prognosticators based on the biology we're still not quite sure on. Ki-67 seems to be an important indicator. However, this may also be a reflection of the embryologic origin. They're intertwined, at least within the studied literature. Baseline promogranins and the evidence or presence of extrahepatic disease are both relatively poor prognosticators, but we really need to elucidate these in much greater detail as the research continues. So in summary, if there's just one take-home slide, I think that this may illustrate what much of the consensus is. Essentially, the application within a local, regional, or ablative therapies is that sandostatin analogs should still remain the cornerstone of management for not only the cytostatic effects, but also symptomatic control. Surgical resection and ablative therapy really follow hand in hand, whether it's during surgical resection with radiofrequency ablation or conceptually thinking of the ablative therapy as a quasi-surgical procedure. And embolic therapy and systemic therapy really fall hand in hand in terms of those conditions where you cannot actually have an intent for cure. The indications for therapy we talked about before used to be considered just for palliation. However, now newer indications for local regional therapy include adjuvant, in other words, pre-surgical optimization or bridging towards a surgical optimization, or testing to see whether there's any other tumor expression as a result following the local regional therapy, or even a potential curative effect if there are oligometastases, primary resected, and there are lesions of less than 3 centimeters in size. We could actually be looking at it with a curative intent and therefore be more aggressive up front as opposed to in the palliative setting. So I'd like to thank you for your time, and I think we'll probably save questions until Dr. Salem has an opportunity to speak.